Good afternoon, my dear students. And today I'm going to talk to you about acute appendicitis. Acute appendicitis. Acute appendicitis means acute inflammation of the appendix. Before I proceed further, I've already talked to you. If you have kindly gone through the anatomy of the appendix, which I uploaded on YouTube, well, the whole advantage and the purpose is that whatever I talk to you, you should see it and listen to it. If you don't see and listen to it, so my talking to you would be some kind of a exercise in futility. So therefore, it is on your request. You people have sent me the message. Kindly speak something. Then I gather my previous uploading of the YouTube. I found hardly anybody who has seen it, because we come to know how many people have seen the talk which I have given. And last time, what I did was I was talking to you about, the surface regions of the anterior abdominal wall, the 9 regions. And with it, I was trying to tell you about the anatomy of the appendix. And anyway, before I go and proceed and talk to you about acute appendicitis, let us revise and review its anatomy. An appendix is a tubular structure at the junction of ileum with cecum. That is junction of small intestine with the large intestine. Okay, and to be exact, it is somewhere around 2 to 2.5 centimeter posterior-medial to ileocecal junction. Appendix is about 4, 5, 6, 7, 10, and sometime it has been noted that it is about 20 centimeters long. And appendix, if you see its diameter through an ultrasound, a normal appendix should have a diameter of less than 6 millimeter. But in case it is more than 6 millimeters, that means we suspect that it may be appendicitis. Appendix is supplied, its arterial supply is by the appendicular artery, which is lies in the mesoappendix. Mesoappendix is a part of the mesentery, and which is, appendicular artery is the terminal branch of the iliac artery. It is a very important structure as far as vascularity of appendix is concerned. And the outer layer of appendix is called serosa. And then there are tinea, which converge at the iliacecal junction. And the inner layer is a circular layer. Then we have a submucosa. And then we have got a mucosa. Mucosa has got, as it's called, epithelial cells. And the argentophin cells also. So coming to the definition of acute appendicitis means that a person has sudden onset of inflammation. I hope you know what inflammation is. Inflammation, for those of you, inflammation is some kind of a reaction of the body against the invading organism, and whenever there is injury to any part of the body, inflammation. If there are some parts of inflammation, you should know what happens is that whenever there is inflammation, there is a pain, there is swelling, there is redness, and the loss of function associated with pain. So it's called, and there's a warmth also, color, reward, calor, dolor, tumor, things like that. So whenever there is acute inflammation of the appendix, whatever the cause, there are so many causes of acute appendicitis, there is inflammation. It may be infection. So coming to acute appendicitis, it is one of the commonest causes of the pain abdomen. And say the lifetime incidence of acute appendicitis in our population is somewhere around 7% or so. Acute appendicitis is more common in those people who have a diet which is rich in, animal proteins. As such, the transit time of animal proteins is slow. The stools are inspissated, and that's one of the reasons that some kind of a, faecolith gets stuck inside the appendix and lumen is blocked. I'm telling you a general observation. And those people who take a diet which is rich in fibers, the incidence of acute appendicitis has been noted to be quite less, just because the transit time of the gut contents is much more, it is given voluminous and fluid type. Then, one of the reasons for acute appendicitis is obstruction of the lumen of appendix because of faecolith or seeds or even the roundworms may cause acute appendicitis. The other causes are because, I have told you last time that appendix is quite rich in the lymphoid follicles. And whenever there is viral infection in children, there is, hyperplasia of these lymphatic tissue. And as a result, there is obstruction of the lumen of the appendix. And it comes, sometimes it used to happen in past that so many people will fall sick because of acute appendicitis. So in children, there's all kind of infections, viral infections and things like that. They are reported to have caused acute appendicitis. So what I told you is the obstruction to the lumen of the appendix because of the faecolith or seeds or round bones, or in the viral infections also, which causes lymphatic hyperplasia and obstruction. The other causes of acute appendicitis is a person may be having malignancy somewhere near the cecum which obstructs the lumen. Another causes of acute appendicitis is some kind of a infection which has come from other places, and appendix may get involved from the adjoining structures also. And then there's a confusion whether, particularly in women, there will be symphingitis or perforates and appendix lying nearby. So that is another possibility. Then, of course, that we have these bacterial infections and acute appendicitis. You see, there is a sudden onset of pain, and if patient does not report to the hospital and the complications set in because of acute appendicitis, there are so many of them, then the diagnosis becomes very difficult. So it may be confused. What we call the differential diagnosis, what can happen is, acute appendicitis can be confused with intussusception. You'll ask me, what is intussusception? Intussusception means telescoping of the gut, where the gut telescopes into the distal part. It can cause similar type. Mcburney diverticulum, Mcburney diverticulitis. So I cannot elaborate much on a Mcburney diverticulitis and things like that, because then the whole purpose of acute appendicitis will go haywire. Mcburney diverticulum, I must say, diverticulum, there's a small diverticulum, wayward extension, like you're going on a road and you find some kind of another road going to some place which are undesirable. So diverticulum is a small pouch like, blind-ended diversion, diverticulum. If that is inflamed, because diverticulum, Mcburney diverticulum, lies about 60 centimeters proximal to iliac junction. It has a heterotopic tissue, maybe pancreatic tissue or gastric tissue, and there may be ulceration because since the gastric tissue is supposed to be in stomach. But here in the Mcburney diverticulum, close to iliac junction, there may be ulceration and things like that. So Mcburney diverticulum, and so many other diseases like Crohn's disease or some kind of a colitis. And it can also occur, in certain situations in which a person is having some kind, it can be confused what I'm saying, acute appendicitis. Like a person has got a maybe infection of the cecum called typhlitis, right? And at times what happens is that a person might have taken something orally and it gets stuck there inside the lumen. And once the disease progresses to a stage where there's a complication, there's so many other things. It becomes diagnostic dilemma in the Pandora's box. Say a person has got a perforated duodenal ulcer. The duodenal contents will escape from the perforation to the right paracaecal gutter down into the pelvis, right iliac fossa. Now, here it becomes difficult to distinguish it from the acute appendicitis, perforated duodenal ulcer. Even there's a large gallbladder is hanging around. We have seen some patients, The gallbladder is very large, and its fundus is going down right up the right iliac fossa, and person has got a cholecystitis infection of inflammation of the gallbladder. It can be confused with acute cholecystitis. Then there are so many lymph nodes in right iliac fossa. So there may be infection of the lymph nodes, mesenteric lymphadenitis. That can also maybe this thing, acute appendicitis. Since the appendix is located in the right lower quadrant, right iliac fossa, the surface, where you find appendix is ileocecal junction, which is called on the surface called Mcburney's point. Mcburney's point is that point, and you draw a line from the umbilicus to anterior spherical spine divided into three parts. The outer third and the junction of middle two-thirds is called Mcburney's point. So that is the place where you find an ileocecal, junction and the location of the appendix. It may also be confused since appendix is on the right side. Just told you what for, but in old times we never had CCT or CT and ultrasound. We merely had, the only investigation which was available to us was X-ray. Ultrasound was also not there. So the diagnosis of acute appendicitis depends even now the history and clinical examination. I'll talk to you about Alvarado score, which to a very large extent is quite sensitive and specific, I must say, in diagnosing acute appendicitis. But you see, it has happened that people have operated a person for acute appendicitis, and after surgery the pain persisted, and then they have taken X-ray and they found a stone in the right ureter. So therefore, what I want to alarm you, warn you, and impress upon you that before you resort to surgery in acute appendicitis, kindly exclude a right-sided ureteric calculus. It has happened, people have committed mistakes. You open the appendix, is a negative laparotomy, there's no sign of appendicitis. And merely just because there was pain on the right iliac fossa, and go ahead and operate in TLC count disease or something like that. We'll discuss it later on. So please exclude right-sided ureteric calculus when you suspect a patient is having acute appendicitis. Then you must exclude, in women in particular, hope it's not of ovarian torsion, salpingo-oophorytis, or salpingitis, or even what? Ectopic gestation. The tubal pregnancy, and lady has got a pain, acute appendicitis, you explore, you find something else. So therefore, you must do urinary HCG studies also in pregnant women to exclude that this is not ectopic tubal gestation. The other causes, which may be confused by the acute appendicitis is obstructed inguinal hernia in children. There is a patent processus vaginalis. It has not yet, closed. And there is a small gut going down in the process vaginalis called obstructed inguinal hernia. So therefore, you must examine the patient totally. You must see whenever there is a pain abdomen, kindly see entire abdomen in totality, including inguinal region and the scrotum also in males. Then the other possibility where you can confuse acute appendicitis in elderly people in particular, there may be some kind of a problem. There may be some rupture of the vessels anterior abdominal wall in elderly people. It may be some kind of a trauma and which is getting confused with acute appendicitis because pain is localized down to right side. All right. And then, of course, patient may have other kind of problems like acute pyelonephritis, urinary tract infections. So all these things must be kept in mind and you must treat. I can tell you that a person who becomes a doctor at this age, really, I'm telling you, these are the corona days, besides the point. I may tell you that I'm putting on, people say, how are you spending your time? At times starting in the morning, getting early in the morning around 5 o'clock, going for a walk and things like that. The golf, etc. is all closed now. The hospitals are also, you're not going to the hospital because of this coronavirus and things like that. We're told that stay back at home. I don't know how in this life a person can waste time. I was reading, frankly, I'm not telling you, non-stop except for lunch or dinner or something like that. 16 hours a day. I was reading. Even I was reading anatomy, whatever books, and a lot of books lying on my bed here, there, and which is a little offensive to the lady of the house. You're made a mess of this thing, and the books lying there. There's some bongo lying over there, something like that. What I mean to say, my dear friends, anybody on this earth who can read and write, there's no difference in a person who educated person if he doesn't read. What is the point? What is the point of education if you don't read the books? You don't disseminate, don't write it, things like that. So therefore, I'm telling you, as medical students or paramedical students, whatever it is, you have to read, because if you read, you will save so many lives. And if you don't read, you become a simple chemist. Patient comes, you write it down. Okay, what are the problem? Things like that. You don't know the side effects of the drugs. What are the reactions? What is the mode of action of the drug? What are the pathology? You don't examine the patient properly. You're going to commit mistakes. A person who does not read will kill many people. A person who does not read, as a doctor, as a surgeon, he will kill patients. Even if you have read a subject 10 times, you are going to operate today. The last night you should have read the topic again and again and again and again. I am telling you that you will save so many lives. And that's what I am doing. Before we will leave this world, I have decided that whatever I'm trying my best to go away from this world fully equipped as a doctor. Anyway, coming back to the point, I was digressing a little bit just to impress my points. Whenever a person has acute appendicitis, please assess his age. Take a detailed history. How did the pain start? The diagnosis of acute appendicitis depends upon the attitude of the patient is walking to you. History, clinical examination, your investigations, and of course, then your treatment. Whether you're going to treat acute appendicitis conservatively, that means without surgery in case there is a lump formation. The additions, the person has put it a little late. But one thing is, I must tell you that be careful in a child and an elderly person if he has got acute appendicitis. Because if you do not operate timely in a baby, in a child who has acute appendicitis, or an elderly person, you are likely to land in complications. You are likely to land in complications. But children are short of momentum. The job of momentum in the abdominal cavity is the constabulary duty. It's like constable goes, police fellow, police gentleman. When there's some kind of a problem, he goes there and protects the people and, controls the situation. But in children, the momentum is falling short. It does not cover the iliac junction at the moment. So what happens is, child having acute appendicitis, the momentum will not be able to seal off the area. It will cover the inflamed appendix to limit the infection. But in a child, God forbid, if the appendix forbids the infection, if the appendix is, has suppuration, there's a pus inside, it will spread all over the peritoneal cavity and cause acute peritonitis. And you examine, there's a guarding and rigidity in the abdomen. Mortality is very high. Please be careful in children and adults in the extremes of age to take timely intervention and resuscitation. And once patient is ready, please go ahead, you operate. Once you operate, you definitely come out with a flying colors, successful. The whole thing is, do not delay, wait, watch, and it's much better to look inside if it is an operable state than to leave it and regret later on. Anyway, now let us start with the acute appendicitis. Its clinical features. Any person, the classical, there's one typical, there's an atypical presentation of acute appendicitis. Let us discuss first the typical presentation of acute appendicitis. Whenever a person gets acute appendicitis and it is not advanced further, A patient will come to you with a periumbilical pain, vague pain. Patient has got a vague pain. He is not able to be very specific. You ask him where is the pain, he'll not be able to tell you here, pinpoint, here. But he says somewhere here is a vague pain, visceral pain, we call it, visceral pain. Because often nerve fibers, nerves, they are unable to, because they're sparse, they are not so, extensive. So you will not be able to appreciate the pain, the cytopathology. And appendix is the mid-gut structures. The person will complain of periumbilical pain. Yeah, here in the middle, umbilicus where you have. This will on and on will carry on. This pain is very, very typical. If today patient says that I had pain here yesterday, but today it has gone on, migrated down to right lower quadrant. I have given you where is right iliac fossa. A migratory pain, typical migratory pain. The pain has shifted from umbilical region, which was quite vague, dull-ache, and now he's shifted to right lower quadrant. Now the pain has become constant. It increases when the person is coughing, or you touch it, or when he moves around. It has migrated to right iliac fossa. So this is called migratory pain. This is typical of acute appendicitis. The pain around umbilicus shifting to right iliac fossa, right? Migratory pain. I'll tell you what is Alvarado score and mentrels and things like that. Mentrel. Remember word mentrel. M-N-T-R-E-L. I already sent it with WhatsApp to you what mentrels means. We'll discuss it later. Now I'm telling you that patient with acute appendicitis has got a pain around umbilicus. Pain around umbilicus shifting, migrating to right iliac fossa and localized there. Why? Because once the appendix is inflamed, there is obstruction, there is a pus accumulation inside, there is a distension of the appendix, the infection goes out. By the way, I'll tell you the pathology also here. When the appendix is obstructed due to a faecolith, what happens? Appendicular secretions from the glands, mucous glands, it distends the lumen. Once it distends the lumen, there are microorganisms within the lumen. Now, this distension of the lumen of the appendix overcomes is much more than the pressure in the blood vessel, say your appendicular artery. So this, due to this distension and pressure inside the lumen, obstructed appendix, it blocks the lymphatic drainage. It blocks the venous drainage of the distal part of the appendix, or distal to the obstruction. And ultimately the thrombosis of the vessels. When the arterial supply is obstructed, the venous supply is obstructed, the entire mucus has become infected then to the pus. So there is ulceration of the mucosa. Microorganisms migrate, bacteria migrate outside into the wall of the appendix and touches the serosa. Now serosa is also inflamed, infected, and this inflamed appendix now touches the parietal peritoneum, the right lower quadrant. And once parietal peritoneum is involved, parietal peritoneum, it is very, what you call that extensively supplied with afferent nerves. And slight touch of the parietal peritoneum is not only the muscles overlying it, but the skin also. There's a hyperesthesia. They all together, all friends get together. 3 people sitting in a row in a classroom. All 3 of them are, pals to each other, friendly to each other. So they sympathize and they get together. So therefore, parietal peritoneum, inflamed parietal peritoneum results in a cutting severe pain and the right lower quadrant, right iliac fossa. And so the muscles also become tense, guarded, like policeman is guarded, stiff. And the moment you touch that area, it is having rigidity, already very stiff. Guarding means a person lying over, but once, you touch it, it'll try to show off, become strict. So guarding rigidity is there, and then tenderness. You press it, You palpate the abdomen, the patient evinces with pain. So these are the features that migratory pain, pain around umbilicus migrating to right iliac fossa is a feature of acute appendicitis. Unless, I told you, this is a typical. It is an atypical presentation when they, due to situs inversus totalis, the appendix may be located on the opposite side. The person will have pain on the left side, left iliac fossa, or appendix may be located in some other locations. I'll discuss it out. The other feature of appendicitis after the pain is that person may have vomiting. Now in appendicitis, there is a pain first followed by vomiting. If there is vomiting first and pain next, then it is not appendicitis. You get my point? So appendicitis, there is a pain, the typical pain I have told you, followed by vomiting, nausea. Then, what else? Loss of appetite. Person loses appetite. Almost 74% of the cases. Right? So there is pain, migratory pain, there is nausea, there is vomiting, there is loss of appetite, and low-grade fever. Person with a low-grade fever. And a person, if he coughs and he gets a pain here, that means it is suggestive of acute appendicitis or Dunphy's. Fine. Thereafter, what happens? Now let us come to, there are certain other clinical features associated with acute appendicitis, depending on the site. Now, on 67 to 75% of the cases, the appendix may be located in a retrocaecal, behind the cecum. The presentation will be different. The patient then will have pain in the lower backside, and if you press it from the front, because appendix is in a retrocaecal position, and in front of the appendix, inflamed appendix, you have a cecum which is full of gas. So if you press it, you will not get pain on pressing, which is called tenderness. Right? 67%, some people say 74%, it varies according to different studies. That appendix may be located in a retrocaecal position, sometimes buried under the tinea. Yeah, tinea in the large gut. The appendix may be in a pelvic position also. In the pelvic position, going hanging into the pelvis, and it may be touching the rectum. The person will have loose motions and diarrhea. Okay, and appendix may be in such a position where it is irritating the ureter or even the urinary bladder. The patient might have hematuria, microscopic hematuria. Microscopic hematuria means in per HPF, what you find is 3 to 4 RBCs. Patient may present with urinary tract type of symptoms, urinary tract infection type of symptoms, in case ureter is involved. In pelvic position, I'm talking about maybe somewhere 30 to 30%.